Today we are going to talk about eye disease of premature infant that is called retinopathy of prematurity, ROP. ROP is a potentially blinding eye disorder that primarily affects premature infants. What are the causes of ROP? Zones of ROP. The retina is divided into three concentric zones centered around optic nerve, which helps to determine the location of abnormal blood vessel growth. Welcome. Today we are going to talk about eye disease of premature infant that is called retinopathy of prematurity, ROP. ROP is a potentially blinding eye disorder that primarily affects premature infants. It occurs when abnormal blood vessels grow and spread throughout the retina, the layer of tissue on the back of the eye that is sensitive to light. What are the causes of ROP? ROP primarily affects premature infants, and it's caused by combination of factors related to immaturity of infants' retinal blood vessels and the medical interventions necessary to support premature babies. And now premature birth itself, it's a risk factors for ROP. The retinal blood vessels start developing at around 16 weeks of gestation and complete nil full term 40 weeks of gestation. Premature birth interrupts this process, leading to incomplete vascularization of retina. The underdeveloped retinal vasculature in premature infants is more susceptible to abnormal growth when exposed to extrauterine environment and medical interventions. Now, those babies that are born prematurely, they need support for breathing, they need oxygen therapy. They often require supplemental oxygen to treat respiratory distress syndrome and other conditions. High levels of oxygen can inhibit normal growth of retinal blood vessels. Excess oxygen can lead to regression of existing retinal blood vessels, a process known as vasoobliteration, which sets the stage for subsequent abnormal vessel growth. Also, fluctuations oxygen levels in those premature babies, both high and low, can contribute to retinal ischemia and hypoxia, promoting the release of something that is called VEGF, vascular endothelial growth factor, that stimulate abnormal vessel growth. VEGF is crucial for normal development of blood vessels. Hypoxia in the retina following the initial phase of high oxygen exposure can lead to overproduction of VEGF, resulting in the proliferation of abnormal blood vessels in retina of those babies as well. Now, low birth weight is a risk factor for ROP. Infants with birth weight of less than 100 grams are at significant higher risk of developing ROP due to correlation of earlier gestational age and associated medical complications in those babies. Inflammation and infections that those babies are often at risk at. Infections can trigger inflammatory responses that may contribute to development and progression of ROP. Also, light exposure in the NICU. The role of light exposure in development of ROP is not well understood, but excessive exposure to bright light has been hypothesized to contribute to retinal stress and vascular changes. Then very often those babies are fed with IV nutrition, parenteral nutrition. The use of parenteral nutrition, which is common in premature infants, can influence the levels of growth factors and other nutrients, potentially affecting retinal development. And medical interventions that those babies need. mechanical ventilation can contribute to fluctuations in blood gases and oxygen levels, influencing the risk of ROP. Those premature babies very often need blood transfusion. Blood transfusions can affect oxygen carrying capacity of the blood and potentially also alter oxygen levels in the retina. Now let's talk about stages, zones of ROP. ROP is classified by location of the disease in the retina, which is zones, the extent of the disease, which is clock hours, and severity of the disease, stages. Understanding these classifications is crucial for diagnosing the severity of ROP and determining appropriate treatment plans. Zones of ROP. The retina is divided into 3 concentric zones centered around optic nerve, which helps to determine the location of abnormal blood vessel growth. Zone 1, the worst location. This zone includes the optic nerve and extends to a radius of twice of distance from optic nerve to something that is called macula. It is the innermost zone and is roughly circular. ROP in this zone is considered more severe because it affects the central vision area around the optic nerve. Zone 2, which is mild and affects peripheral retina. This zone extends from the edge of zone 1 to zone 3, which is the most peripheral. ROP in zone 2 can be serious, but generally is less critical than zone 1. And finally, zone 3. This is the outermost zone and includes remaining kind of crescent shape of peripheral retina. ROP in this zone is usually less severe and often resolves on its own. Now, stages of ROP. ROP progresses through 5 stages, reflecting the severity of abnormal retinal blood vessel development. Stage 1, mildly abnormal blood vessel growth. There is a demarcation line, a thin, flat, white line separates the vascularized retina from avascularized retina, and stage 1 often regresses without any intervention. It's a mild stage, mild disease. Stage 2, moderately abnormal blood vessel growth. There is a ridge formation. There is a demarcation line that develops into kind of a ridge with height and width, indicating more pronounced abnormal vascularization. Prognosis in this zone, stage 2, prognosis in this stage, stage 2, is still good. The chances of regression without any treatment is very high, but this stage requires close monitoring. Stage 3, this is severely abnormal blood vessel growth. There is extraretinal fibrovascular proliferation. Blood vessels grow abnormally from the ridge into the vitreous. Vitreous is like a gel-like fluid that fills our eye. Prognosis of stage 3, there is a higher risk of progressing to more severe stages, and treatment is often necessary at this stage, stage 3. Stage 4, it's severe stage, it's partial retinal detachment. Prognosis, there is significant risk of vision losses. Usually stage 4 requires surgical intervention to prevent complete detachment. And finally, the last stage, stage 5, there is a total retinal detachment when the retina is fully detached. Prognosis of stage 5, there is a high risk of severe vision impairment or blindness. Surgical treatment has limited success, unfortunately, in stage 5. Now, let's mention something that is called Platt's disease. Platt's disease is an additional classification that indicates increased severity of disease, severity of ROP. It's characterized by vascular changes. There is a marked dilatation and tortuosity of the posterior retinal blood vessels, and the presence of plus disease denotes a more aggressive form of ROP that often requires urgent treatment. Something that I want to also mention is the clock hours, extent of disease. The extent of ROP is described by the number of clock hours from 1 to 12 that are affected. And those clock hours refer to circumferential extent of the disease in the retina, with each hour representing a 30-degree segment. How do we screen and diagnose ROP? Screening for ROP involves regular eye examination by a pediatric ophthalmologist for babies that are at increased risk. These examinations typically start at few weeks after birth and continue until the retinal blood vessels are fully developed. The classification into zones, stages, presence of plus disease guides the management and treatment decisions. And now, what is the treatment of ROP, retinopathy of prematurity? Treatment aims to halt the progression of the disease, prevent retinal detachment, and preserve, obviously, vision. The treatment approach depends on severity of ROP, specifically the stage and the zone of disease, and what are the approaches for different stages and zones of ROP. Stages 1 and 2. Many cases of mild ROP, so stages 1 and 2, can resolve on their own without any intervention. It's important to regularly monitor regular eye exam by pediatric ophthalmologists. This is essential, and infants are usually examined every 1 to 2 weeks to track the progression or regression of the disease. If intervention is required, needed, what options do we have? The first option, laser therapy. Laser therapy is used to treat severe ROP, particularly in zone 1 and 2, so close to the optic nerve, with stage 3 or worse. These treatments are used to stop the growth of abnormal blood vessels by destroying the peripheral areas of the retina. A laser is used to create burns, kind of burns in the peripheral avascular retina, destroying the tissue that produces abnormal blood vessels. This treatment, laser treatment, reduces the production of VEGF and other growth factors that promote neovascularization. Laser photocoagulation has been shown to significantly reduce the risk of retinal detachment and severe vision loss. Advantages, it offers more permanent solution compared to some other therapies. It has a long history of effectiveness in managing of ROP, but it has potential side effects because it can cause peripheral vision loss and other complications due to destruction of retinal tissue due to those burns. Another option, more frequently used now, it's anti-VEGF therapy, intravitreal injections with medications such as Avastin. Avastin is injected directly into the eye to inhibit the action of VEGF and reduce abnormal blood vessel growth. It's particularly used for zone 1 ROP and aggressive posterior ROP. The medication is injected into the vitreous cavity of the eye under sterile conditions. Regular follow-up exams are necessary to monitor the response of Avastin and detect any recurrence. Advantages: it directly targets VEGF, that is reduces abnormal blood vessel growth. It's less destructive because, unlike laser therapy, it does not destroy retinal tissue and may preserve peripheral vision. And one more option, one more interventions that are used are surgical interventions. Two of them, scleral buckling and vitrectomy, which is removal of vitreous gel and fibrous tissue pulling on retina. Those surgical interventions are used for the most severe stages, stage 4 and stage 5 of ROP with retinal detachment. And those procedures can improve the chances of reattaching the retina and preserving some visions. Those surgeries also provide a chance to save vision in advanced cases that would otherwise lead to blindness. If we talk about prevention of ROP, preventing ROP involves addressing the risk factors that are associated with premature birth and optimizing the management of premature infants to reduce the incidence and severity of the disease. And prevention includes prevention of premature birth, so prenatal care, regular checkups, ensuring that expectant moms received regular prenatal care. That helps to monitor and manage potential complications that could lead to even premature birth. Then treatment of infections in those moms, early indication and treatment, identification and treatment of infections during pregnancy can help to prevent premature births. Routine screening for GBS infection and providing appropriate antibiotic prophylaxis during labor can reduce the risk of neonatal infections and contribute to premature delivery. Then managing premature labor, tocolytic medications, using medications to delay preterm birth can provide additional time for babies to become more mature, for fetal development, especially lung maturation. Administration of corticosteroids to moms that are at risk for premature delivery. It helps to accelerate fetal lung development and reduce respiratory complications in premature infants. And then, very important, when those babies are born, care in neonatal ICU. Careful monitoring of oxygen therapy, so target oxygen levels, using carefully controlled and target oxygen therapy helps to maintain appropriate oxygen levels in those babies, avoiding both hyperoxia, which is dangerous, and hypoxia, which puts those babies at risk for ROP. Oxygen saturation targets, so maintaining oxygen saturation levels within a safe range, usually it's between 90 to 95%, helps to prevent fluctuations, big fluctuations, that hypoxia and hyperoxia that can lead also to ROP. Using non-invasive ventilation, so CPAP and IPPV, continuous positive pressure, airway pressure, and nasal intermittent positive pressure ventilation, again reduces the need for high oxygen concentrations and mechanical ventilation, lowering the risk of ROP as well. Minimizing fluctuations in oxygen levels, stable oxygen delivery, ensuring stable oxygen delivery with minimal fluctuations helps to prevent swings, those swings in oxygenation that can trigger abnormal retinal blood vessel growth. What else is important in care of those babies in NICU? Nutritional support, promoting breastfeeding. Breast milk provides essential nutrients and growth factors that support healthy development and may reduce risk of ROP. Parenteral and enteral nutrition, providing balanced parenteral and enteral nutrition ensures that preterm infants received adequate calories, proteins, vitamins, minerals to support growth and reduce risk of ROP. And then finally, very important, early screening and monitoring for ROP, regular eye examination, Implementing standardized screening protocols for ROP ensures early detection and timely interventions. Screening for ROP typically begins at 4 to 6 weeks of age after delivery, or 31, 33 weeks corrected gestational, whichever it's later. Infants born before 30 weeks of gestation or weighing less than 1,500 grams are at higher risk of ROP, and they require regular eye examinations. What is the prognosis of ROP? The prognosis of ROP varies widely based on severity of the disease, the timing and effectiveness of treatment, and other individual factors. And obviously, early detection and appropriate management are crucial for improving outcomes. And what factors affect prognosis of ROP? First, severity of ROP. So mild stages, as we mentioned, stages 1 and 2. Many cases of mild ROP, stage 1 and 2, regress spontaneously without any treatment. These infants often have normal or near normal vision as they grow. Moderate to severe ROP, so stages 3 to 5, the prognosis is more advanced. In those more advanced stages is more guarded and can vary significantly, and very important is prompt and effective treatment. It's essential to prevent progression to retinal detachment and severe vision loss. Prognosis of ROP also depends on location of ROP. So zone 1, ROP in zone 1, central retina is associated with higher risk of poor outcomes due to critical role in this area, and in the central vision it's close to the optic nerve. Zone 2 and 3, ROP in those zones generally has a better prognosis, especially if it's detected early and treated early. And then presence of plus disease, so those dilated and tortuous blood vessels in the posterior retina indicates more severe and rapidly progressing form of ROP, which typically requires urgent treatment and carries higher risk of poor outcomes. What are the long-term visual complications of ROP? Many infants, as I mentioned, with mild ROP achieve normal or near normal vision, but it's important that they have, after discharge from NICU, regular follow-up with pediatric ophthalmologists to monitor for any late onset complications. And those late onset complications are refractive errors. This is a common issue even in infants whose ROP regresses or it's successfully treated. Refractive errors such as myopia, so nearsightedness, astigmatism, or anisometropia, which is a difference in prescription between two eyes, are common. These refractive errors can often be corrected with glasses or contact lenses. The next complication, long-term complication, it's something that is called amblyopia, so lazy eye. Some children with ROP develop amblyopia, lazy eye, which requires treatment with patching or atropine drops to strengthen the weak eye. Another complication, strabismus, so misalignment of eyes, strabismus, crossed eyes or wandering eyes are more common in children who had ROP. Treatment may include either glasses or patching or even surgery. Sometimes babies that are treated with laser therapy, they can have visual, as I mentioned also, visual field losses. Photocoagulation can lead to some loss of peripheral vision due to destruction of peripheral retinal tissue. And finally, in those severe stages of ROP, stage 4 or 5, where there is a partial or complete retinal detachment, those babies are at higher risk of severe visual impairment or blindness, despite even treatment and surgical interventions. So follow-up and long-term care for those babies that were diagnosed with ROP is very important, and they need to be seen by eye specialists to monitor for any vision problems as they grow. I think we covered most important points in regards to ROP. If there is any questions, you can contact me at neonatologyforparents.com. Thank you.